For those of you who I haven't had a chance to meet in the VMR space before, my name is Jack. I use he, him pronouns. I'm one of the CP Solvers team members, and I'm really excited to get to be here for this very special Saturday VMR session, where we get to join forces with the Emory Residency Program, work through a case together, and hopefully create an opportunity for those of you who have joined to not only learn some medicine, but also learn more about this fantastic program. I will kick it over to some of the team members to introduce themselves today. But it feels like the next person that should be chatting here should be our very, very special guest today. So Kevin, I'm going to pass it over to you to introduce yourself to everybody.
Thank you so much. Hi there. I'm Kevin. Last name Ryment. I am one of the PGY2s here at Emory in Internal Medicine. Yeah, I guess I'll leave it there.
Awesome. Thanks so much. Do you mind telling us a little bit about yourself in terms of how you arrived at Emory, things you like to do outside of medicine and presenting cases on Saturdays?
Happily, yeah. So I'm actually from Wisconsin, the Milwaukee area originally. Was a lifer there. I did my first undergrad over at UW in Madison, my nursing degree at UW in Milwaukee, and then medical school back out in Madison. Kind of came to Emory just because it was such a fantastic program as I was doing my residency program research. Really wanted to come here because I knew it was going to offer really very excellent clinical training and just would make me the strongest internist I could be by the end of it. And so now obviously I'm loving it, working very hard, but enjoying every minute of it. I guess if I'm not in the hospital, I've recently got myself back into running, which is nice, except that there are a lot of hills in Atlanta, I've learned, and Southeast Wisconsin is not known for topography. So it's been a challenge to try and build that strength back up.
I feel you. Thanks so much, Kevin. Alex, can we come over to you now?
Certainly. Good morning, y'all. I'm Alex Metelsky. I'm one of the chief residents currently at Emory. And so when we have a little time at the end, I'm happy to chat with you more about the program and go into detail. But I'm originally from Chicagoland, actually. That's similarly to Kevin. I'm a Midwestern lifer up until my time at Emory. University of Illinois for medical school, and then here for Atlanta for residency. I'll be doing infectious disease next year. Outside of the hospital, I am particularly fond of cooking and trying new recipes. The latest attempt has been like an orange and clove pork loin. So that one turned out pretty well. Always open to new recipes. If you want to toss me some in the chat, I'll give them a try.
Right on. Thanks, Alex. I saw everybody's eyes lit up when you mentioned the pork loin dish. So I think if there is ever a VMR potluck where we can all come together, I think that'll be high on the menu.
Brilliant idea.
And then it wouldn't be a day with Emory or any VMR day if we didn't at least pass the mic over to Yusuf to say hello to everybody.
Hey everyone, good morning, good afternoon. I'm Yusuf, one of the residents as well. I'm very, very excited that all my worlds are overlapping today with Alex and Kevin. Alex and Kevin are both very highly respected in our program. We also work together in the narrative medicine group. I'm very excited to invite people who are intellectually curious and wouldn't leave a stone unturned without learning about it and using every opportunity to learn and teach. So I'm very, very excited to join the session today.
Awesome. Thank you so much, Yusuf. And then certainly the last but not least, folks, the two individuals who I am absolutely over the moon to get to discuss with and learn from today, Deborah and Tansu. Tansu, maybe I can pass it over to you first to say hello.
Hello, friends. Welcome. I'm so excited for our discussion today. My name is Tansu. I'm an IMG from Turkey. And outside of medicine, I love playing with my two cats and teaching them tricks and doing Lindy Hop.
Thanks so much.
To you, Deborah.
Hi, everyone. I'm Deborah. I'm currently in Argentina, moving to the US in a few days. Here is super hot, as you can see here. And what I like to do outside of medicine, I do CrossFit, and it's something that I really like it. I'm excited for the case today.
Awesome. And of course, VMR would not be possible without the fearless and tireless work of our teaching points and case scribe for today, which will be Anmolpreet and Navpreet. Anmolpreet, can we turn it over to you to say hello to everybody before we get started?
Hello, everyone. My name is Anmolpreet Kaur, and I'm a recent CP Solvers member. So I'll be doing this teaching points today, and I'm an international medical graduate from India. So happy to be here. Looking forward to the case.
Thank you so much. And Navpreet, we'll turn it over to you before we get started.
Hello, everybody, and my name is Navpreet. I'm also international graduate from India, and I'm doing scribing today. Really excited for the case.
All right. Well, as always, the purpose of CP Solvers VMR is not necessarily to solve the case. We will hope to do that, but what we will certainly do is analyze the case, practice our clinical reasoning, build out organized and systematic approaches to clinical problems. Most certainly learn something along the way, and even more certainly, if Tansu, Deborah, and I do our jobs correctly, have a ton of fun over the next 45 minutes or so. So with that in mind, we can go ahead and pull up the whiteboard. And Kevin, we will turn it over to you to get us started.
All right, sounds like a plan here. So I hope I'm not going too fast as we're starting to describe here. But our first aliquot of information was just kind of our chief complaint, which our patient, first and foremost, is a 46-year-old woman. History of atopy, both asthma and atopic dermatitis, and a recent COVID-19 infection about a month prior to presentation, coming to the hospital with complaints of a sore throat and pain with swallowing.
All right. Deborah and Tansu, we have this kind of interesting space here of both these kind of background symptoms, but really sort of the foreground of a sore throat or pharyngitis and pain with swallowing or odynophagia. I'll turn it over. Maybe I can come to you first, Deborah. Maybe we can just start by kind of chewing together on this initial chief concern of a sore throat.
Yeah, it's interesting. Like, I don't think we go much through this sore throat, and make me think how long time this patient is having this, and how is like this sore throat, like if the patient when is swallowing, eating something, if it's hurting or if it's hurting like all the time, like without doing anything. And I would be wonder like if that happened before or like it's the first time. Make me think like something in the pulmonary tract, like some pharyngitis, something like in the way to the lungs, if could be happening. If could be something related maybe with the asthma, or could be something else. I think that could be my first thoughts.
I love so much that you're zeroing in on the time course here, right? Because the tempo of this sore throat is really, really important, right? Most of the time when we see individuals who have a sore throat, it's usually over a few days. I had a cold about a month ago. I had a sore throat for a few days, but a month is a bit of a longer tempo of illness that we might expect for our sort of classic upper respiratory tract infection associated sore throats. So I'm curious, Tansu, like if you look at these symptoms kind of happening over a month, does that shift the types of diseases that you're thinking about here at all?
Absolutely, because I'm moving from more like acute infections to more subacute to chronic space, given the 1 month 1 month course of the symptoms here. And I would first also like to look at if there is a respiratory compromise here too, given the patient has a sore throat and difficulty swallowing. So I want to see if there's drooling as well, or if the patient is in a tripod position. So a respiratory compromise that I could interfere and make the patient feel better. But given that the patient had been having symptoms for 1 month, I'm not as concerned about the typical infectious causes of acute infection, and I'm moving towards more like maybe a typical infections or maybe other causes like malignancy could be a consideration since it's such a long time course.
Excellent, Tansu. I think that is absolutely fantastically analyzed here. Now, if you don't mind, I'm just going to pull up, take over the screen for 1 second here, and just share kind of an approach to pharyngitis that we can use to potentially anchor us here as we get more information from Kevin. So let me just pull this up for 1 second. Is everybody able to see this okay? So let's just kind of walk through briefly here, because I think both Deborah and Tansu brought up super important points here, right? Deborah really highlighting the fact that the time course plays a huge role here. And if we pull up and look at this kind of graph in the top left here, we see that the different categories of illness will have very different tempos, right? Infections are usually high amplitude, severe sore throats that last for a short period of time, usually days. Non-infectious causes tend to be a little bit slower and smoldering, whether that's autoimmune diseases or possibly underlying malignancies like Tansu mentioned, and they might start to extend over a longer period of time. And then sometimes there are actually environmental exposures that could lead to a sore throat, particularly in somebody like this who's known to have a history of atopy, right? We may see that certain environmental allergens could lead to their sore throat, could lead to symptoms flaring in fits and starts over time, which we can see here by this kind of green line here, right? The sort of waxing and waning symptoms. So if we look and say, okay, well, maybe we're dealing with non-infectious sources, let's just sort of look at the overall possible causes of a pharyngitis, right? And we know that itis just means inflammation of the throat. And we have a framework in the CP solvers that we can fall back on when we think about inflammation, and that's IMADE, right? So we'll think about infectious causes, we'll think about malignancy, autoimmune diseases, drugs, endocrine disorders, and then a second E that we add in is the environmental causes. Most of our classic infections are going to be the acute ones, like these sort of viral pathogens or these bacterial pathogens. When symptoms start to last longer, we may think about granulomatous diseases or fungal diseases in the immunocompromised hosts. But longer lasting symptoms, we may also broaden the framework to include malignancies, like Tansu mentioned, whether that's lymphomas or leukemias. Certain autoimmune diseases can potentially come into play here, particularly the vasculitides, if we're dealing with an airway-centric disease, and then some drugs, endocrine, and the environment come into play, right? So this is a way for us to anchor in to our pharyngitis approach here, acknowledging that we'll probably get much more information that further shapes how we're thinking about this. Navpreet, I'll give you back the whiteboard now. And now we have to say, well, what do we make of the odynophagia here? And so, Deborah, maybe I can come back to you. When you see this sort of odynophagia or severe pain with swallowing, are you thinking that this is all explained by the sore throat, or could there be another structure in the body involved here?
I think could be another structure. Like I was thinking, we talk a lot now, like about infection, but maybe not necessarily could be an infection. Maybe it could be something else. Could be like the patient could have another disease associated. That's where my mind is.
Yeah, absolutely, absolutely. Tansu, any thoughts from you about sort of like what other structures could be involved other than the oropharynx that are going to make it really painful to swallow?
So I'm thinking about the retropharyngeal space here, especially after Maddie's wonderful case where we saw the Ludwig angina. So any tissue structure, anatomical structure surrounding the oropharynx, and one of them is being retropharyngeal space is in my mind right now.
Yeah, awesome, right? And we can just trace where saliva goes as we swallow, right? It starts in our mouth, goes to our throat, right? It may touch areas in the back of our throat. And then where is things that we swallow, where are they going to go next? When they go into the stomach, as they make their way to the stomach, what are they potentially going to pass through? I'll take this one. They're going to go into the esophagus, right? So we have to ask ourselves, are we dealing with just a pharyngitis, or is this potentially a disease that impacts the esophagus and we're getting esophagitis, right? Some of those fungal infections that we talked about, namely esophageal and oropharyngeal candidiasis, could give both. There are certain other viral infections that are much less common, right? Like herpes, HSV esophagitis that may give us vesicles in the oropharynx and in the esophagus. So we know that the pharynx is in play here, still yet to be determined if the esophagus is in play. But if it is, it could help us kind of, again, shape the different categories of disease that we're thinking about. All right, Kevin, take us forward here.
All right. So the remainder of our history here, I'll take us back to that previous COVID infection for her. She was briefly hospitalized over a period about 8 days for that. She did not have hypoxia with that prior COVID infection, but was febrile, discharged, and then did return to work fairly shortly afterwards. About a week prior to presentation, she did start to develop fatigue and malaise. Made it difficult for her to work at that point. And then about the morning of presentation, started to develop that sore throat and had noted a sore on the very back of her tongue, a posterior aspect of that. In talking with her, on her review of symptoms with that, still was having the malaise and the fatigue with all of this, but notably denied any kind of fevers, chills, night sweats, no kind of dyspnea or cough, no nausea, vomiting, diarrhea, no hemoptysis or hematemesis, no headaches, and no other bits of lymphadenopathy, no bruising, no dysphagia, no drooling, or changes to her voice. I can pause there if we need to get caught up on the describing.
That's perfect. Feel free. I think we're getting caught up here, Kevin. Thank you.
Great.
Thank you for
All
the
right.
pause.
So the past medical history for her was notable for that asthma, as I noted earlier. For that, she just takes as needed albuterol. It's quite rare for her to use it, maybe a few times a month by her report. Also has a diagnosis of anxiety for which she's been put on venlafaxine. She was taking 450 milligrams of that daily for the last 5 years or so. Was also prescribed propranolol 40 milligrams twice a day. That she had not been taking reliably over the last couple of months. And then her other medication was trazodone, which she took nightly PRN for sleep. She has no surgical history, and her family history was notable for a few cancers. And her father had melanoma. Her maternal grandmother had lung cancer. Maternal grandfather had colon cancer. And then her mother had been diagnosed with rheumatoid arthritis. And then her social history, she works as a 4th grade teacher. She is unmarried, and she denied any kind of substance use, never smoker, very rare alcohol use, no recreational drug use.
All right. Does this feel like a good place for us to pause? All right. So, I think we're getting some more information coming forward here, particularly clarity about the time course of these symptoms. And it sounds like the tempo of the COVID infection was a month ago, but actually these oropharyngeal symptoms are much, much more acute. And then we have the addition of kind of a sore on the back of the tongue. And maybe, Tansu, maybe I can come to you first here. What do you like when you see there's a sore on the back of the tongue? What is your brain doing with that information, just kind of in general and as it relates to some of the other findings that we're seeing here?
I mean, if I didn't know any of the other information, and if I just know that the patient had a sore in the back of the throat, I would think of first infection and then some autoimmune diseases that causes oral ulcerations. And then I could even think of like malignancy as a cause of an ulceration in the mucosal oropharyngeal space. And it was very interesting, actually, that this patient, as a sign of inflammation, I was expecting more signs of inflammation, maybe presence of fever, or like maybe weight loss, night sweats, that kind of thing. But we hear that the patient has only malaise. And now it's kind of shifting the needle, for me at least, towards the malignancy space and autoimmune diseases a little bit. And hearing about the pain with swallowing, especially, I'm curious about if the patient is in an immunocompromised state, if she has maybe HIV, that could increase the possibility of first and foremost candidal esophagitis, which would be mildly painful, and then CMV and HSV esophagitis, which would be more a lot more painful than candida esophagitis. So I want to know the patient's immune status, and I would also like to know other like physical exam findings and vitals and all of that.
I think that was an absolutely phenomenal overview there. And I appreciate so much, right? You're kind of pulling in, right? They're pulling in all of the potential categories of illness of ulcers, but also being super specific with us about what specific pathogens you might be thinking about, what specific underlying autoimmune diseases or malignancies you may be thinking about. Deborah, if we look at her past medical history here, right, there's some of these interesting features in kind of the problems that she's known to have. But then her family history, at least for me, I was pretty struck by her family history. I'm curious, what are you making of some of the things that we see in her family history, especially in terms of how it relates to what Tansu was just mentioning?
Yeah, like when I saw the family history, I got a little surprised because it's a history of cancer with a lot of the father, the mother, the grandmother. So that made me wonder if she could, she could have like a cancer, if this could be like a manifestation of a cancer, and make me worry about that.
Yeah, 100%, right? We see that there is maybe not necessarily a syndrome of malignancy arising in the family, but maybe some potentially increased risk based off of how many first-degree relatives have it. And then certainly a first-degree relative with an underlying autoimmune disease, right? We can sometimes see an autoimmune disease tends to beget more autoimmune diseases. So those may also come into play here. I'm hearing us kind of starting now to maybe use the finding of the sore or the ulcer as a way to not necessarily anchor us, but start to sort of serve as maybe one pivot point for us to go forward. So let's just kind of talk a little bit here about kind of oral ulcers in general. There's actually relatively quite common, whether it's like low-level minor things like canker sores that all of us may develop with time, versus sometimes they can be signs of more sinister diseases. Tansu, maybe I can come back to you. Does the number of ulcers that we see change things for you? In other words, like a single solitary ulcer in the mouth versus like multiple scattered ulcers within the oropharynx?
Yes, so if it was a single ulcer and if it was painless and had kind of like a grayish mucosal background, I would think maybe of syphilis. And if it was multiple ulcers, I would think of like some other respiratory pathogens. It could be even like EBV or CMV, that type of respiratory bugs that's seen in maybe more in younger age group. So the patient being 46, but it doesn't, of course, eliminate the possibility. But so if we had multiple ulcers, I would think of an infectious respiratory pathogen. And if it was more like a chancre sore of like painless ulcer, then it would point me towards something like syphilis. And also if I saw maybe like not one, but oligo ulcers, like maybe a few, but not so many, then that would also make me think of like autoimmune diseases. And I'm thinking of like Behçet type of picture. And if the patient has genital ulcers, I would also check that. And since I have concern for autoimmune diseases here, I would also like to know if the patient has any joint pain or like intermittent fevers, rash of any type in other parts of her body.
Yeah, excellent. That is, I think, so well said. And then Deborah, let's say that we got more information that there's just been a single progressive ulcer, like on the back of the tongue or in the back of the mouth. It's just like one deep erosive lesion. Would that change things for you in terms of like maybe it makes autoimmune diseases more likely versus making cancers more likely?
Yeah, I think you say like it progresses with time, the ulcer, and don't like heal. That's what you mentioned. Yeah, I think like could be more like the causes that tend to said like autoimmune, like a BSHAT, or like we said about the family history of cancer. She could have like a cancer, a malignancy. No, of course, that will go my thought in that direction.
Yeah, I'm totally with you, right? And I'm hearing from both of you the two big variables that we can use to kind of understand or make progress on analyzing the presence of an oral ulcer. One of the big variables is going to be whether it's recurrent or persistent or just there for a short period of time. And the other variable is going to be the presence or absence of prominent systemic symptoms, right? If we start to see prominent systemic symptoms, right, we may start to think about the infections that Tansu mentioned, particularly STIs like syphilis or HSV or HIV, or we're going to think about systemic autoimmune diseases, the list we kind of already went through. Whereas if it's isolated and single and persistent, we start to potentially think about the probability of cancer ratcheting up a little bit, right? That could be solid cancers like oral squamous cell carcinoma, or liquid cancers like, for example, lymphomas. There's a certain variant of lymphoma called an NK cell lymphoma that has a slight predilection to cause oropharyngeal disease like this, particularly things in the mouth or on the back of the tongue. So I can't pretend to know exactly where this is going to go, but I think those are some of the variables that I'm looking for here, right? As we get to the exam, right, it'll be very important for us to understand not only the geography of where this lesion is, but how many they're there and what other company it's keeping, right? If we see cottage cheese-like findings in the mouth, right, that may push us in one direction. If we see an oligo ulcers, I love that, Tansu, as you mentioned, that's going to push us in another direction. And like you said, Deborah, if we see a deep ulcer back there that's singular, right, it might increase the probability of cancer here. But we're going to also keep our eyes peeled beyond the mouth, right? If we see joint findings, rashes, other prominent systemic symptoms arising, right, we'll have to take that into consideration as we frame, is this an isolated oral disease or a systemic disease that happens to be hitting the oropharyngeal space? All right, Kevin, we'll come back to you here.
All right, I'll move into the physical exam here.
Kevin,
vitals for her. Oh, yeah, sorry, Alex.
Before you jump on the physical exam, I might ask any sexual history, sexual practices for her. I think that might be relevant.
It's a great question. So I believe, if I remember correctly, she had been sexually active previously, but not recently, to her memory. Previously had almost exclusively used protection with her exclusively male partners.
Great. Good to know. And I think one thing to point out whenever we're asking sexual history is be really open-ended with the question, because then you can get to things like, does she engage in oral sex, which would obviously change the way we think about the types of things that her mouth and throat have been exposed to, right? So fantastic addition in there. Thanks for adding that, Kevin.
Absolutely. Thanks, Alex. All right. Vital signs for her were notable for her being afebrile at the time of exam, 98.7. Her blood pressure was 130/90 with a pulse of 80 at the time. Respiratory rate was 12, and she was satting about 98% on room air. BMI for her was 39.5. Generally on her exam, she was very well appearing. On the morning after admission, when I met her, she was busy cracking jokes with me about being back in the hospital again. Was otherwise doing pretty well. Her HENT exam was notable for a little bit of right-sided submandibular tenderness without any major masses or lymph nodes in that area to speak of. She did, in her oral cavity, have some evidence of macroglossia. Her Mallampati score was probably a 3 bordering on a 4, just a lot of excess tissue within the oral space. And then on the posterior aspect of her tongue, really had to dig back a little bit to try and get a view of this ulcer. But as much as I was able to appreciate was small, maybe about a centimeter across with a clean base, nothing heaping up across the edges of it, and it was quite shallow. No drainage coming from that area either. She had no pharyngeal erythema, no tonsillar exudates, no kind of unilateral tonsillar swelling, and normal phonation while we were speaking to each other. And the rest of, lymph nodes, to my exam at the very least, there were a couple of small, palpable, maybe mildly tender right-sided cervical lymph nodes, but nothing on the left side. No supraclavicular, no axial, no epitrochlear, no inguinal lymph nodes that I was able to appreciate. And the rest of her exam was extremely benign. Heart had a regular rate and rhythm, no murmurs on that, no dependent edema for her. Lungs were very clear to auscultation. She was not using any kind of accessory muscles. Belly was obese but soft, and no hepatosplenomegaly that I could appreciate. Neuro exam, she was alert and oriented. I was moving for extremities, no focal deficits there. No rashes, no evidence of joint swelling, no pain with any kind of joint mobility, anything to speak of there.
All right. So our physical exam here, right, is sort of helping us really, I think, make progress on the fact that the center of gravity of this case is sort of seeming to be kind of in and around this area of the body, right? There's no clear, at least at this point in time, right? Things may change and evolve, but nothing pulling us away from the oropharyngeal cavity. And we have sort of a couple pieces of information here, right? We have this sort of tenderness in the submandibular area on the right side, some local lymph nodes in that area, and then this ulcer that we're seeing on the back of the tongue. So Deborah, maybe I can come to you, right? How is sort of the things focusing on the oropharyngeal space helping you at all at this point in terms of some of those categories that we were talking about, right? Cancers, autoimmune diseases, or infections that may typically cause ulcerative lesions in this space?
Yeah, when I heard like the lymph nodes, I thought about like that could confirm some of our thoughts of HBV or some infection like mononucleosis, TB. Always we can think that could cause something like that. Make me think lymphoma of Hodgkin too, that could cause that. That was my thoughts when I heard about the lymph nodes. And yeah, besides that, the patient, the vitals are okay. So maybe, make me less worry about the patient. And yeah, that's where my thoughts are.
Excellent. Tansu, anything to add?
So it looks like an indolent picture to me more than a fulminant picture. So, and the sore being painless on a clear base is making me think of a syphilitic chancre at this point, or a malignancy like a squamous cell carcinoma of the mouth, of the tongue, or a pharynx. So I'm more in the like indolent infection or malignancy, or maybe still autoimmune space right now.
Excellent. I'm with you both. I think if I were to sort of look at what we're dealing with here, there's a couple of things that are interesting here, right? We talked about some of the primary infections that we would think about in this space, for example, HSV infections. One of the things that is interesting about this is that oftentimes initial primary HSV infection tends to be a much more inflammatory disease process where you may get things like fever, local lymphadenopathy, and some of the primary findings there. And one of the ways that I was sort of thinking about pulling in HSV into this is like, oh, this is somebody who recently had a COVID infection. There's maybe underlying illness that could weaken her immune system and lead things to flare for her, right? Lead to her having a flare of disease. But the flare of disease would be a disease recurrence rather than a primary infection. And so there's a bit of a discordance there in terms of how she might be developing these symptoms in relation to her recent COVID infection compared with some of the clinical symptoms that we're seeing here, which is maybe a more prominent infection with some localized lymphadenopathy, and it sounds like quite significant pain. So I don't have much to add to you both in terms of the differential here. I think if I was seeing her in practice, I would send tests for most of the infections that you all mentioned, right? The common things like we could think about looking for HSV, we could think about EBV, although I think it's hard to make a strong case for that without like big bulky tonsils at this point in time. We might also, again, wanting to characterize her underlying immune status and making sure that this isn't an HIV infection. And then if those tests come back negative, then I think we have to, as you all were saying, start to expand the differential and be like, oh, wow, this is a localized sore with some nearby draining lymphadenopathy that is not falling into one of the common types of infections that we may see, like a common viral infection, potentially a common bacterial infection, or a common sexually transmitted infection. And from there, right, then I think the things start to widen a lot. So I think that's one direction that this may go, right? Our sort of first pass diagnostics will be unrevealing and we have to broaden the spotlight, or there's going to be another type of evolution of this disease process that's going to make us reframe the problem altogether. And rather than saying that this is a primary oropharyngeal disease, right, we might say, oh, this is actually has developed into a systemic disease that happens to have the oropharynx as one of the places that it is tending to impact here. So yeah, I'm with both of you. I think both pathways are very possible at this point in time, and we'll just have to see where things go from here. But Kevin, we'll turn it back to you to take us forward.
Sounds great. All right. So getting into her labs, CBC here was notable for a white count of 1.8. Hemoglobin at admission was 11.4 with an MCV of 85 at the time, hematocrits 34.5, and then a platelet count of 190. The diff for her was notable for an ANC at admission of 0.01. And then by the morning where I had met her was back down to an ANC of 0. Lymphocytes were 1.06, monos 0.4, eos and basos normal at 0.02 and 0.01 respectively. Her chem panel was notable for basically stable electrolytes and renal function, sodium 137, K of 3.5, chloride 104, excuse me, bicarb of 24, BUN of 9, and a creatinine of 0.6. Her liver function panel was also essentially normal, an AST of 17, ALT of 16, ALK Phos of 90, and a Billy of 1.0. One notable historical point for her as well was the fact that during her prior hospitalization, she was, for COVID a month ago, was noted at that time to have an ANC of 0 as well. Her count spontaneously recovered during that hospitalization, so she was discharged on just neutropenic prophylaxis. Yes, that was the history on that.
All right. Well, I'll be honest with you. I feel both anxiety and relief at this point in time. The anxiety is because this is a fairly sinister problem for us to deal with, but also some relief here because it gives us more and more of a clear picture of what exactly the problem is that we have to solve, right? And we have this glaring finding of what sounds like fairly persistent neutropenia, and not just neutropenia, but profound neutropenia, right? We might even put this into the category of something like agranulocytosis. So Tansu, maybe I can come to you first here. What are you making of this very, very prominent lab finding here, and how might you think about making progress on this?
So I was actually thinking that the patient has pancytopenia with the low white blood cell count, anemia, and platelet count is also low. And this made me concerned about maybe like a bone marrow infiltrative process. It can be infections or like autoimmune disease or malignancy still, but it's very, or drugs that can cause neutropenia and underproduction in the bone marrow. So it's very concerning. And those were my initial thoughts, like a process involving the bone marrow.
Excellent. Excellent. I think those are great points. Deborah, what about like where might you think about going next here in a case like this, where we have these sort of lab findings here? How might we make progress from a diagnostic perspective in terms of what could be driving this severe neutropenia, and as Tansu mentioned, also pancytopenia?
Yeah, I think from here we could order all the infections that we were thinking about now with this WBC low, I'm thinking about HIV. So I wonder like ABC, HIV, hepatitis, EBV, like just I will start from there and then I would make next steps.
Excellent. So I'm here and we're sort of thinking about, okay, maybe our diagnostic journey is going to end here in the bone marrow, as Tansu mentioned. But Deborah, you're saying we need to pass through some other key checkpoints along the way. Look for infections that may be associated with underlying neutropenia, or infections or other diseases that may lead to the development of pancytopenia. And I think that's a very wise journey for us to take here, right? If we zoom out and say, what is the problem that we have here, right? We have a 46-year-old woman who had a recent upper respiratory infection, has a history of atopic dermatitis, and maybe some family history of underlying autoimmune disease, who is coming in with now fairly persistent neutropenia here after a recent illness. It sounds like, Kevin, there was maybe some rebound, but never really a full, complete rebound of her neutrophils after the initial presentation with COVID.
That's correct. By the time of discharge, her neutrophils had started to come back up again, or were at least hitting, I believe it was about the 200s ANC, but never got above 500 before discharge. And obviously, by the time she had come back to us, they had started to drop one more time.
Okay. So if we kind of take that into consideration with what we have here, with what seems like a pharyngitis or a pharyngeal illness, we can at least start to better understand what could be driving this kind of ulceration and this pharyngeal illness. If we remember back to the framework that we looked through at the beginning, one of the causes of pharyngitis is agranulocytosis, right, which usually involves profound neutropenia. Agranulocytosis is usually a drug-induced process, and those are going to be drugs like antipsychotics. Some antithyroid medications can do it. Sulfasalazine can do it, as can Bactrim, right? So when we see isolated neutropenia alone and pharyngitis, we might say, okay, we might look for some of those meds on her medication list, which we don't necessarily see here, right? We don't see a history of her getting antithyroid diseases. We don't see a history of her getting antibiotics like Bactrim or other sulfa drugs like sulfasalazine. And some of the antipsychotics that can commonly cause agranulocytosis aren't necessarily on here as well. So then I think we have to take the exact path that you both took, Deborah and Tansu, which is say, okay, well, what other processes could cause relatively persistent neutropenia like this? In a 46-year-old, we could think about infections that may have a particular predilection for the bone marrow, and we can think about certain underlying autoimmune diseases that can do it. I'm a relatively simple internist, and so simple frameworks help me. The way that I like to think about it is that connective tissue diseases, things like lupus or other connective tissue diseases, they tend to cause cytopenias. And vasculitides like EGPA or GPA tend to cause leukocytoses, right? So as Tansu was saying, we have cytopenias, oral ulcers in a middle-aged person with a family history of autoimmune disease. We may start to go look for underlying connective tissue diseases, starting maybe with an ANA and then proceeding from there. Right? But there are certainly other processes outside of autoimmune diseases or some of these atypical infections that can cause diffuse, or I should say pancytopenia and prominent leukopenia. And those are going to be processes that you mentioned, Tansu, that may hit the bone marrow, right? Maybe I'll ask each of you, right? If I were to tell you this is a disease that is definitely going to be positive on bone marrow biopsy, what are some of those bone marrow-based diseases that you would specifically be worried about? Maybe Deborah, I can come to you first. Things that can replace normal cells in the bone marrow. Is there anything that comes to mind?
I'll think about leukemia, maybe multiple myeloma too.
Nice. Awesome. Tansu, anything else?
Yeah, I'm also thinking of lymphomas, and I'm actually thinking about like some infections too, like maybe parvovirus. I don't know if it's going to be a too far stretch, but given that she's a teacher and has like exposure to little kids, so and it has a predilection for the bone marrow, I'm thinking of like that.
Excellent, excellent. I think you both have charted us a path forward, right? We're going to maybe be sort of setting our coordinates towards examining the bone marrow, but we're going to hit some key serologic checkpoints along the way there. So Kevin, let's see. I'm curious where you all ended up taking this case from here.
Yeah, so as I think all of y'all are, we started to cast a very wide net in how we were pursuing our workup. So I kind of bucketed follow-up labs for us into a few different categories for us. But infectious things that we ran through for her was negative HIV serologies, negative hepatitis B and C serologies, CMV and EBV PCR on her blood were both negative. She tested negative for COVID on this admission as well. And HSV PCR was negative. During the previous hospitalization, they had also run a quant gold that had come back negative for her. And a subsequent hospitalization also ran blastomyces antibodies, which came back negative for her as well. On the nutrition front, we got back normal levels of zinc, copper, and folate. She was previously found to be deficient in B12, but had been supplemented. And so when we checked, she did come back normal on that. And then during this hospitalization was found to be fairly mildly iron deficient as well and was started on repletion there. On her rheumatologic labs, we ran an ANA, which was negative for that as well. She had reported to us a history of a positive ANA. We were unable to confirm that during our hospitalization. And then an anti-CCP antibody and rheumatoid factor were both negative as well. And then on the malignancy workup, our SPEP and UPEP did not demonstrate a monoclonal spike. And during the previous hospitalization, peripheral flow cytometry also did not demonstrate any kind of monoclonal lineages for that. I was also seeing in the chat demand for a peripheral smear as well. We did get that. There was no dysmorphia within the cell lines there, only confirming the neutropenia and then some mild hyperchromia on her red cells. I can give the bone marrow that we got during that stay as well here that did demonstrate arrested maturation and near total granulocyte aplasia with some evidence of ongoing immature granulocytes, but nothing achieving a maturity on that test. And then some mild to moderate reticular myelofibrosis. But staining for EBV, AFB, and fungi were all negative on that.
All right. So I think many of the questions that we had initially asked, infections, underlying autoimmune diseases, and even the bone marrow examination, right? These have all kind of come back and been largely unrevealing here. Our bone marrow exam gives us some clues, but at least from my vantage point, not necessarily a definitive answer here. And so, right, we don't see some of the characteristic findings that we might see with a leukemia, like blast, but we have this very, very prominent granulocyte aplasia here, right? So we can, I am no hematologist or hematopathologist, but when I see very immature granulocytes and granulocyte aplasia, the term agranulocytosis starts to come to mind. Tansu and Deborah acknowledging this is we have sort of found ourselves in a corner that internists will seldom, problems that internists will seldom have to solve on their own. But I'm just curious, like when you, as you find yourself here now, what things are potentially coming to mind, either in terms of diagnoses, other tests to send, just kind of think out loud in terms of where your mind is going at this point here. Deborah, maybe we can start with you first.
I got a question. They did like Inca for rheumatologic.
We actually did not run ANCA antibodies during that hospital stay. I don't believe that was ever included in her workup on the subsequent checks.
Okay. Yeah, like right here, I'm trying to think where else we should go. Like I would definitely like talk about hematology about this bone marrow, like, and maybe check like the lymph nodes, like maybe do a biopsy, and or like has like a good call for help, good insight, DSF. I would definitely call for help, like definitely like for hematology, like with this bone marrow, if they can help, and maybe like Hans had a good idea about the medication. Maybe it's like something that we could think about it too, or like any other infection that we didn't have here yet. That's where my thoughts are right now.
Yeah, I'm with you, Deborah. I am super stumped at this point in time. I commend whatever team ends up solving this case, because I don't think it's one that I could do on my own solo here. So I'm with you, right? I think this is a space that's important for us to know as clinicians, right? When we have maybe reached the sort of edges of our knowledge here, because there might be a strong desire to be like, oh, I can do this, I can solve this. But I think I'm right there with you in that the edge of, I think I have found the end of my rope in terms of being able to understand this problem space. So I commend you for leaning into the uncertainty there like that, because I think if you and I were seeing this case together, I would be right there with you. Tansu, I'm curious if you have any other thoughts on kind of where we could go from here, or other things that are coming to your mind as you see this bone marrow biopsy, or even just as you think about how you might manage through this case in practice?
Yeah, so some of my hypotheses are depleted at that point, and I was thinking about maybe like drug side effects. So I would look into like if any of the drugs that this patient is on has any like bone marrow suppression effect. And also I'm still thinking like maybe parvovirus, would it be a possibility? We didn't hear about parvovirus serologies here yet, so I'm thinking maybe that could be a possibility. But it seems to me that the lack of maturation, the arrested maturation, is centered around the granulocytes, and there's mild myelofibrosis. So I'm thinking like drugs. I would check her med list and then consult hematology.
Yeah, Jack,
Excellent.
one more
I'm
thing.
right there. Yeah.
Well, one more thought, like when I get stuck like in a case like this, I always like to go back to the beginning and see where we are, like how did we start, what are we are missing, then just keep ordering like labs and imagings, like, and nonstop. Like I always like to review, go back to the beginning, make more questions for the patient, for the family, try to understand more to see like if we are missing something.
Excellent. Excellent. I'm totally with you there. And I think the path forward that you both took, I think, is our suggestion that we take is absolutely spot on. One of the things that I at least try to push myself to do in cases like this, where I'm like, I am totally stumped, is to sort of say, okay, well, we're going to reach out for help, but let's predict some of the things that they may say, or some of the data points that they may use, right? And if we look at kind of how this disease has unfolded in the absence of another place to really hang our hats, one of the things that I think has kind of been lingering in the background that may take center stage now is the temporal association here with the COVID infections. I have been fooled so many times by COVID activating certain other underlying autoimmune conditions. And I think the sort of cyclic nature of this and the timing kind of around her recent COVID infection at least makes me curious about the possibility of COVID activating the immune system and sort of unmasking an underlying autoimmune disorder, as you both kind of hypothesized early on. There is a super rare clinical entity called autoimmune neutropenia. And so that would be one of the questions that I'd make, to the hematologist, is this a thing that you might think about here, or a thing that you could, that you can sometimes see after COVID infection? Because I feel like time and time again, there has been some sort of a vague autoimmune-ish syndrome that comes out around COVID, whether that's a hematologic disease like a thrombophilia or a clotting disorder that has come about. And so that's just one of the things kind of circling in the back of my mind here that we might pose to the help that we call for here in this case. But I think the most educational thing for us to do next is going to be to hear from Kevin in terms of where this case went, what the final diagnosis is, and kind of how the team got there.
Absolutely. So during this hospitalization, in conjunction with our hematology team, we sort of settled on the idea of this most likely being a case of what was explained to me as cyclic neutropenia, which seemed to be responsive to some Granix stimulation that she received during that hospitalization and afterwards. Now, there's a little bit of inconsistency with all of this, that she was then seen up at Dana-Farber for kind of a second opinion on all of this. And they, at that time, started to think a little bit more about the possibility of an autoimmune etiology to this, just because this was so late in onset, which wouldn't necessarily fit with something a little bit more genetically related, like cyclic neutropenia. The third possibility has also been kind of a medication side effect as a result of her venlafaxine. She has now been weaned off of that and is onto an SSRI instead for anxiety management. And most recently here, her counts have been recovering for the last 2 or 3 months. The last check earlier this month was 1,900, so getting back towards normal again.
Super interesting, incredibly challenging case. And Deborah and Tansu, I just want to commend you both for reasoning through or wading through, at least for me, feels like one of the more challenging cases that I have I think ever contended with in the VMR space, which makes it incredibly educational for us. Kevin, thank you for taking us through just this really wonderful journey through. We started in the oropharynx and ended in advanced testing from the bone marrow, which is evidence of a really fantastic diagnostic journey along the way here. In the interest of time, I want to make sure that we allow for time here, and we can absolutely go over the 1 o'clock Eastern mark here, but want to turn it over to you, Alex, to have some time to really center the incredible program that this case has come from, and where so many of you all joining us today are joining from, to talk to us a little bit more about Emory.
Yeah, thanks, Jack. Really appreciate that. Kevin, wow, fantastic case. Loved the direction it took us, and super smart work from Deborah and Tansu on getting there pretty much. I think you walked us right into the end of the diagnosis. All we needed was a hematologist and oncologist help, right? So great. I'm happy to take any questions about Emory in general. I can certainly give some general commentary too, if nobody has any specific questions, but this is y'all's time, and thanks for joining us today.
Yeah, I think if you want to go like some general things about Emory will be a great start.
Sure. All right. Fantastic. So Emory is obviously here in Atlanta, and it's a pretty large program. We have about in the neighborhood of 150 categorical residents, plus or minus a few every year. And we have an additional 50 or so transitional year residents who are going into things like dermatology, radiology, who spend time with us on the medicine wards, obviously during their first year. So all told, we have a lot of residents that are rotating, and we have 4 different hospital sites that we cover. So here in Atlanta, we have the main university campus, and then we have our Midtown Hospital, which is an Emory hospital that sort of has more of a community feel. We have the VA, which is where I am the chief currently, and so that's obviously where we serve veterans of Central Georgia and Atlanta. And then lastly, we have kind of what I think everybody considers the crown jewel and one of the most incredible training sites at our program, which is Grady Memorial Hospital, our public safety net hospital that we all really love to be at, where the patients are both incredibly sick and incredibly thankful for the care they receive, and we absolutely love that place. So, as a program as a whole, obviously we pride ourselves a lot on being clinically rigorous. People walk away as a very competent and confident physicians, and that's something that we really strive for, both through our education and through the experiences that we have. And then I think the other thing that we can really say about our program is, in spite of its size, there's a lot of really great camaraderie among the residents. People are there for each other through a lot of the challenging components of residency. And I think that's emblematic, or what's perhaps most emblematic of that would be our narrative medicine program, which is something that Yusuf had mentioned earlier. A lot of us participate in collaborative writing meetings where we can chat through some of the really hard things we experience together and try to process them and think through them and be there for one another in those moments. So that's the general overview. We love it here. We love Atlanta. It's a great city. And I would be happy to expound upon any of that more, but I've talked enough for the moment.
If Yusuf or Kevin want to share something with us, we would love to hear.
Yeah, so what I would add to what Alex said is that, like Alex said, Grady is one of our hospitals, and there's this common theme here is that because like how socioeconomic status can affect healthcare, as healthcare workers, we feel like we're on the front lines of helping people, and there's this culture of service at Emory, where like everybody who wants to join the program is looking to help others, has like a history of serving the community, volunteering, so on and so forth. And I think that leads to a culture of kindness where almost everyone is very, very kind, wants to help one another, and regardless of who you talk to in the hospital, everybody's very like kind, wants you to grow, and so on and so forth. And I think that's very unique.
I'm just going to co-sign all of that. I keep on saying that I have gotten extremely lucky with all the folks that I've been surrounded with. I don't think that's actually luck, though. I'm fairly certain this is just a self-selection coming into this program of just very, very good folks. And I think they're just a joy to be around for my training.
Amazing. And we normally get a question like about research, if you all have opportunities to do research during residency, if you can answer this question, any of one of you three.
Sure, I'd be happy to take that, Deborah. Fantastic question. So I think, maybe it would help first just to add some context. The plurality of our residents go on to fellowship. So like probably 60%, again, plus or minus every year, will go on to fellowship. The rest will do either hospital medicine or another engagement after, like a research chief or a clinical chief, or even one of our chief residents in quality and safety. So obviously, with a lot of energy geared toward making sure people are well prepared to match into the fellowship of their choice, there are lots of opportunities for research and lots of both formal and informal pathways by which to be involved in research while you're here. I say some of the great formal ways that we do it. We have like a prime mentorship program, which is if you have an area of interest, then the leadership of the program will work to find mentorship for you, get you engaged in a laboratory or a clinical research group that matches and aligns with your interests. And then there's lots of informal pathways too, obviously. I think, again, going back to the theme of this is a very big place. So there are Emory faculty in every niche of the various subspecialties doing lots of different types of research projects, and you get introduced to a lot of them just based on where you're rotating through. So, for example, as an intern, you have a dedicated month of an inpatient cardiology service, which is where a lot of our cardiology-bound residents may meet a research mentor just while rounding with them on the wards on heart failure patients. Or during your second year, you get engaged in subspecialty selectives like bone marrow transplant and transplant infectious disease and others, again, where you just might informally run across somebody. So I happened to round with Dr. Stephanie Pouch on the transplant ID service. She ended up writing one of my letters of recommendation for ID fellowship down the road. So both these informal and formal pathways, I think, are really great ways to find those coaches and mentors. And I think that's obviously one of the most important parts of your training is people have done this before, and you need the advice of those who have come before to get there.
Thank you so much for your answer. I think we have two more questions. Tansu, do you want to go first, and then you can go, Leandro?
Sure. So you mentioned about the narrative medicine track, and I'm curious what other tracks are there in your program and how they are integrated into the regular clinical curriculum. So if you can comment on that a little bit, that'd be great.
Sure. So I'll clarify a little bit. The narrative medicine group is actually more of like an extracurricular, I guess you could call it. Just a group of people who are all interested in writing and speaking and trying to process things through an art form. But we do have a lot of distinction tracks at Emory, and so everybody at the halfway through their first year sort of decides what distinction track they'd like to participate in. These run the gamut from like a social justice oriented health equity distinction track where the participants do a lot of advocacy at the local level. They go to the state capitol, which is right here in Atlanta, and advocate for legislation to help protect patients or reform certain things that are affecting patients' health, like the carceral system in America. Or the POCUS distinction, which is where they have both dedicated didactic time and then personal ultrasounds that they take around to the wards, help them practice, turning POCUS into an extension of their physical exam. And then like the HIV distinction, which is what I was a participant in. And that's great because, some of your clinic time becomes time at the Ponce de Leon Center, which is our Grady affiliated, Emory affiliated primary HIV clinic in Atlanta. And Atlanta has the highest rate of new HIV diagnoses in the country. So that's a very unfortunate statistic for Atlanta, but a really incredible place to be able to train because you get to take care of so many people living with that burden. So all those distinctions, and there's others beyond that too, but are something that everyone will participate in. And so everybody gets a kind of their own little bit of flavor that changes the trajectory of their day to day and their week to week while they're a resident.
Thank you so much.
Leandro, you want to do your question?
Yeah, sure. Thank you. Well, first of all, my name is Leandro. I'm from Venezuela. I'm applying to internal medicine, and Emory is one of my top choices, to be honest. I had a question regarding the patient population that you get to see. I know that there are 4 different hospitals that you were talking, and Grady takes care of a largely underserved population. But I really want to know a little more in depth. I've never been in Atlanta, so maybe talking a little more about what specific patients you get to see, and maybe what specific pathologies that you have seen in Grady. And also, my second question is regarding the med students. If you have a lot of involvement with med students, and yeah, if you can grow as a teacher while being a resident.
Fantastic questions. Yeah. I've been doing a lot of talking, so I'd be happy to respond. But if Kevin, Yusuf, or I see Daniel Matthew, one of our other residents, is actually on here too, just to learn. So one of y'all want to mention some of the stuff we see at Grady or the type of patients we get to take care of?
Maybe Daniel, we didn't heard him yet.
Hey everybody, I'm Dan. It's so great to be here. I actually work really closely with Alex and Kevin, Yusuf, so it's just so wonderful to see them all on the screen. That's such a good question. I think one of the things that I have really appreciated about just being here with these people is there is such a huge emphasis on teaching at every level. And so for me as an intern, I just get a lot of opportunities to engage with the med students. They rotate with us on the wards. There was a service actually a couple of weeks ago. I was with Alex and Kev actually just right across the hall. And there's just so much great team communication. There have been times when, Kev would bring us over and just talk through a topic with us. And we would share that with our med students. I think the biggest plug that I could give for Emory is the collaboration and the teaching that exists at every single level. It doesn't start at the attending level and go down to the resident level. It truly is top to bottom, bottom to top. And to me, that's just been so wonderful. And I can't say enough about it. You had another question. I know I think I got to one part.
About the different patient populations that you get to see in the 4 hospitals.
Oh, yeah, absolutely. I will also defer a little bit of this to Yusuf and Kev, but I think one of the things that I've really appreciated is at the 4 different hospitals, because, for example, Grady is really focused on caring for very vulnerable patients, and you have a VA population, there's such a unique focus that you bring to the table. And then, of course, at Emory University Hospital, where you have these very, very complex cases, it's just so wonderful to be able to take your training, this fund of clinical knowledge, and then apply it to different contexts and just see, okay, how can I fit this information to the patients I have in front of me? I think that's been the most rewarding for me.
Thank you so much for being with us. We didn't heard from you before. And we can ask another question about the city if anyone want to share all of you could share a little bit. It could be our last question. What do you think about the city? Did you enjoy? Any recommendations when we go visit?
Yeah, so I can take that one. Thank you, Dan. The city, like Alex said, is very, very green. If you're flying over Atlanta, you will see like a lot of greenery, and it's sort of like a big city feel. And then right, very, very close to it, you can feel like, oh, you just went to a smaller town, and it's more like houses between trees and so on and so forth. It's like has a diversity of scenery. It's a southern city. There's a lot of southern culture. Everybody's like very nice. There's a million hikes around, like literally more than 20 hikes that you can go to. A diversity in food and richness in culture. It has like a very, very big, one of the biggest airports in the country, and you can like travel to almost anywhere through a direct flight, which is fantastic. And I don't know, what would you add to that, Kevin?
I mean, I would add that the Atlanta airport is the busiest in the world. So what I mean by that is that it winds up leading to very thriving and active immigrant populations and communities around the city, which I think is super cool to have. I said at the beginning that I'm a Wisconsin lifer, so this has been an incredibly different situation for me to be in, but I think also very like consciousness expanding on my part. So it's been nice being here and getting to experience something so different than what I've experienced previously.
As someone who
Guys,
loves food, the food scene here is incredible as well. I'll just give that a quick plug too.
A lot of good restaurants, absolutely.
oh, so thank you so much, you all, for being with us. Thank you so much, Kevin, for this amazing case. We passed a little bit of the time, but the conversation and the case was so good that we didn't notice. We really appreciate, and we all want to say that you all welcome back. Like we have like Yusuf and Nidhi from the program. They're always with us, and it's always a pleasure. So thank you so much for spending time with us in this Saturday. And yeah, good luck for all the applicants. Bye-bye.
Everybody, thank you.